All right. Good morning, everybody. It is 10 a.m. and welcome to this quarter's Tobacco Cessation Learning Community Call. Today, we're going to be talking about faith-based partnerships for nicotine recovery, why we want to do them, and some words on how. Most of you already know, but I am Jim Pavlik. I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program. We're in the Department of Psychiatry at the University of Colorado Anschutz Medical Campus. Today's objectives are fairly straightforward. I'm going to review the person-centered health neighborhood. Those of you who've been around for a while will definitely have heard that term before. For a lot of you, it will be review. For some of you, it may be new. I just want to make sure that we're all on the same page. So I will be doing a little bit of level setting on that particular topic. Then we're going to define the role of community of spirits. What role do communities of spirit play in creating the person-centered health neighborhood? Community of spirit is sort of an alternative phrase for faith-based organizations. It's a little bit more inclusive of sort of alternative paths that people can take. Then we're going to describe several different kinds of such community. And then we're going to identify points of strategic alliance between public health agencies and faith-based organizations. So I want to begin. All right. Some people are finding ways to unmute themselves. I'm not sure how that's happening. All right. So I want to begin this presentation on faith-based partnerships with a very brief discussion on what we at BHWP call the person-centered nicotine recovery health neighborhood, because fundamentally, I want us all to view our faith-based partners as neighbors with whom we share an obligation of service to overlapping communities. Going forward, I will just be referring to the health neighborhood rather than this longer, clunkier version. Just know that when I refer to the health neighborhood, I am in fact most concerned with the nicotine recovery component. As I said before, for some of you, the next few minutes may be review, but if it's not review for you, then I recommend at some point checking out the 3-module series called the Tobacco Cessation Health Neighborhood, which is available on BHWP's YouTube channel. And I think it is also available at Tobacco Free CO. To understand what the health neighborhood is, we first need to understand why it is. Historically, in public health, we have always viewed community-based partners as locations where we can place health interventions. You'll even hear some of that old modality used in today's slides, as much of the research into faith-based partnerships precedes the era of the so-called public health 3.0 reframing that underlies the health neighborhood concept. And I will say that seeing community-based partners as a location for the delivery of services is not necessarily a bad thing. It's at least one step better than not seeing community-based partners at all. But perceiving them as mere destinations for health delivery runs contrary to the truth, which is that communities are where people get sick or healthy. They are the true source of our health. And viewing individual locales as mere service delivery intercepts ignores the whole for its parts and undermines the opportunity for true partnerships. When public health entities take prefabricated health education, health promotion, or disease prevention programs into communities looking for allies, these end up being one-way, top-down approaches to reach our goals. So that's the first thing to keep in mind. We have to recognize that we are neighbors too, that none of us are healthy unless all of us are healthy. We are not the government coming to help the people. Our ideas are not better. They're just ours. To effect real change, we have to engage with communities, and we must do so from a perspective of humility and equality. The other thing we need to keep in mind is that health does not exist in a vacuum. I know many of you are aware of the concept that's being communicated on this slide. The US outspends all other OECD countries and yet has poor to middling health outcomes. Not the worst in the world, but not the best, and in some cases, the absolute worst. But here's the thing. The US is unique among OECD countries in that we have separate funding streams for physical, mental, and social health. And if you add up all of this spending across all of these domains, then America isn't the top spender among OECD countries. We're just above average and near the median. And so with middling spending, we get middling results. And of course, it's not just that America is spending across all health-related domains a middling amount. By pumping so much into just medical care, we are misallocating funds from where they could be more impactful. The fact is that health derives from a variety of sources, and medical care is a very small amount of it, somewhere in the vicinity of 10%, depending on the specific studies that you're looking at. Far more important than that are our social circumstances and our physical environments, which collectively make up about a third of our health outcomes, 3 times higher than medical care alone. And more important than that are our individual behaviors, like our diets, our drug use, and physical activity. And all of these things take place within the context of our social circumstances and our physical environments. It's hard to go to the gym if the gym is 30 minutes away and not located on a bus line. It's hard to buy healthy food if you live in a food desert. It's easier to smoke and harder to stop smoking if you live in a neighborhood with a higher density of tobacco retailers and fewer recovery treatment centers. And these neighborhood level effects can be quite pronounced. Pictured here are clusters of tobacco retail outlets in and around low-income neighborhoods. This pattern emerges in city after city after city. It is not coincidental. Not only are there higher density retailers in low-income neighborhoods, what this map is actually showing you are higher density of tobacco retailers around WIC clinics. This is intentional. The tobacco companies have long used geography to target potential consumers with advertising, with retail opportunities, and with price discounts like direct mail coupons. And of course, it's not merely the presence of more tobacco outlets, but a host of things like lower quality housing, reduced to non-existent access to medical care, job instability, violent crime, etc. And we can see that across just a few miles, life expectancy can vary by as much as 13 years between, for example, on this map, Globeville in the north and the Hilltop neighborhood in the south, which are just over 5 miles apart. And we can see the impacts of these policies at almost every level of analysis. So I've highlighted here some pretty stark differences at the county level, again, with 5, 8, and 16 and a half years difference in life expectancy within just a short car ride from one another. Geographic disparities require geographic approaches. So how do we do that? Well, for tobacco cessation, we're going to take the 5 A's, and rather than view it as a single process for a single isolated healthcare clinic, as it has historically been conceptualized, and we're going to explode it across the community into a constellation of care sites. The 5 A's was developed by primary care physicians to be used by primary care physicians within the time span of a routine clinical encounter. For those who don't know, the 5 A's are ask, advise, assess, assist, and arrange. And those things describe all the elements of an evidence-based nicotine recovery intervention that has been shown to increase both the number of quit attempts that occur as well as the success of those which are undertaken. And this is how it has historically been taught and performed. A single clinic, sometimes a single clinician, does all the 5 A's. And now, of course, most clinics and most clinicians have historically been too busy to adopt the 5 A's, so most adopt what we call the 2 A's and an R. And in this model, the clinician asks the patient if they use tobacco, and if they say yes, they refer them to another provider to handle the rest. Normally, this other provider is the quit line, and that's the end of it. We call this model the 2 A's and an R, ask, advise, and refer. But we know that this has not historically gotten us all the results that we want. Not enough patients are being asked, even less are receiving the advice to quit, and even fewer are being referred. And for whatever reason, those who are not asked are those who are disproportionately more at risk of nicotine use and dependence, including lower income individuals. And those who do not receive referrals are from similarly disadvantaged groups like those with a mental health diagnosis. So how do we repair that? Well, we begin by turning this destination of care into a neighbor. And that means emphasizing the role of continuity of care protocols. All HIPAA-covered entities that refer to the quit line via fax can receive directly from the quit line the status of those individuals that were referred, whether they were lost to contact, whether they went through intake, and whether they were fully enrolled in services. Of course, even if the clinician doesn't receive a fax back, they should still make a note in the patient's chart to follow up with them about whether any referrals or recommendations were pursued, and if so, to what end. Of course, the whole point of the health neighborhood is to expand our partnerships beyond traditional healthcare and out into what we call untraditional points of care or untraditional partners, which may include other government entities like libraries, schools, courthouses, jails, and prisons, and outward to the object of today's discussion, faith-based organizations, and honestly, to anyone else that wants to play along. The idea is to identify the individuals in your community that need the help, and then develop programs to reach them in their communities wherever they live, work, play, and pray. So with that goal in mind, let's talk about what we mean by faith-based organizations, or FBOs, and why we want to work with them in particular. And let's start with the why. First and foremost, we know that spirituality is a dimension of wellness, and we know that nicotine use, and particularly nicotine dependence, runs afoul of many people's own conceptions of what it means to live in accordance with their personal spiritual or religious beliefs. And the reverse is also true. Many people, even non-religious people, find that spirituality, a sense of something greater than themselves, or having a bigger sense of their purpose in life, all contribute to their recovery. On that point, there is a difference between religion, religious beliefs, spirituality, and religious or spiritual acts, activities, etc. For the most part, I'm referring to what have historically been called faith-based organizations, but some more recent conversations have supported the term communities of spirit. The fact is that these are not entirely synonymous groups. I know that. I prefer communities of spirit personally, but the academic literature primarily uses faith-based organizations, so that's what I'm going to be referring to. And when I'm using that term, what I'm referring to are any group that explicitly refers to the spiritual domain as a specific source of guidance, perhaps in their strategic goals, their mission, their vision, or their values. Mostly that is going to mean the traditional faith-based organizations that we're used to talking about. Right, that includes churches, mosques, synagogues, temples, and other places of worship, and the institutions that own, operate, or oversee those places, and in those places hold rituals, rites, and ceremonies. But I'm also talking about religious nonprofits like the Salvation Army and also hospitals. And these are entities that, for reasons that I'll mention again later, many public health agencies feel more ease working with, because even though faith is a leading value that underpins their mission, the strategies they use to accomplish their goals are through public service and or the provision of healthcare services. But I'm also talking about schools. And here I'm talking about elementary, middle, and high schools, but also universities, and those schools that exist explicitly to train leaders within the church, whether those are clerical, priestly, or other. And related to that are what I would call those organizations that exist to advance development within their faith bodies. And this could be professional development academies or entities that exist to develop faith among their community of faithful. And so just to make that clear, I'm thinking here of organizations that run retreats as an example. There are interfaith organizations, which are organizations whose mission is to liaise between their church leadership and the leaders of other faiths. One of the more important entities for today's discussion are religious media operations, some of which are quite large. But the reason I would like people to consider them is because media operations are always good partners for disseminating information or raising awareness about program offerings. Less commonly thought of in this context of FBOs are yoga studios, mindfulness centers, and other kinds of retreat centers or organizations. Here we see that there are quite a few options here in Colorado. The top 3 types all number over 100. Excuse me. That's across Colorado. And actually, what you're seeing here would include the top four because I pulled out a category called Christian nonprofits. I pulled them out of this graph just so that this graph is a little bit more legible. Because as you can see, there are almost 3,000 of the other, which would really distort the scale a little bit here. So we can see on this chart, or on this graph rather, that there are religious professional services, religious media, Catholic nonprofits, Islamic, Jewish, and Buddhist nonprofits. If we're looking at just those nearly 3,000 Christian, they say, this website that I'm referencing down here calls them Christian. They really probably should say Protestant nonprofits, but this is their label, not mine. So we can see, as you might expect, that they are highly concentrated in the various population centers, right? Churches and other sorts of worship organizations are where the people are. So that's going to mean, of course, right here in the Denver metro area, along the I-25 corridor, and then over in Grand Junction. Now, I'm not singling out these Christian or Protestant nonprofits for any secret advocacy agenda. It's just that their sheer number compared to the other types, I thought warranted taking an extra look at their distribution. If you do want to see the lists of all and the locations of all the different types of organizations that are listed here, like on the other chart, then you can head over to Cause IQ. You can see the link to the table where I pulled this information from there at the bottom left of the slide. Yeah, head over there. I'm not endorsing Cause IQ. I don't really know anything. I don't really know anything about them, including how they made their determinations of who was to be included in these various databases. However, I know from experience that the first and hardest part of developing community-based partnerships is coming up with a list of who to contact. And this website can go quite a long way in helping you form that list. So I'm going to take a quick break on this title slide just so I can take attendance via screen share or screen grab. There we go. So now that we know who we're talking about and why we want to talk to them, I'm going to spend the rest of this presentation talking about how. AI helped me generate that image. Thank you, AI. I want to start with challenges for two reasons. One is that they are important and we should be mindful of these challenges before we start attempting to engage with them. But the other is rhetorical. The other option is that I would end this section and therefore this presentation with the challenges, and that's just kind of a downer. The point I want you to take away is that the challenges are real and they are important, but the potential benefits here make the partnerships worth pursuing. So the first thing to keep in mind is that faith-based organizations are a closed group, and they can be naturally suspicious of outsiders reaching in and trying to help, quote unquote, help, particularly the government or other ostensibly secular institutions. We'll repeat this point a few times over the next few slides, but it's important to develop trust any way that you can, but particularly through open communication. Lay out your aims, lay out your concerns, listen to their concerns, and listen to their goals. On that point, you have to remember that your goal of nicotine recovery isn't likely to be their main goal. It may, at best, be a tactic in some other goal that is subservient to the larger goal of living their life in accordance to their spiritual aims. We often talk of strategic alignment. In my personal opinion, we almost never actually mean strategic alignment when we use that phrase. Rather, we are often aligning our strategies with their goals or tactics. In any case, we must keep at the forefront of our mind that one of us in this partnership will be working on the big idea that underpins your organization, and the other one will be working on something related, but less important. The next big challenge is sustainability. There are sustainability issues on both sides here. FBOs can change leadership and priorities pretty quickly, especially on things that are not doctrinal. That is, they can choose which ministries exist, who leads them, how they're funded, the centrality that they're given over other public interest spaces, etc. This can lead to the breakdown of the partnership simply by removing the individual who was the point person in that relationship. And government agencies often only have access to a year or a few years worth of funding. They are subject to the policy and initiative whims of various levels of executive leadership, etc. So do make a point of addressing sustainability from both sides at the beginning of the partnership, and then collectively or collaboratively work out ways to be sustainable in the context of whatever sustainability challenges you both identify. One really key area of difficulty is the adherence to evidence-based strategies, or in the context of deploying pre-made psychoeducational materials, fidelity to those programs. Religious groups require that the programs they run or even just endorse adhere to their specific set of rules, norms, customs, values, etc. And sometimes that means adjusting the content of those materials. Whether and how much a program is adjusted, I think, needs to be taken on a case-by-case basis. But generally speaking, I would default to being more acquiescent than not. In most cases, having a trusted entity saying you should quit nicotine, however they say it, is just going to be better than having them not address it at all. I would look specifically and closely at whether or not certain delivery adjustments might cause harm. Those would be hard stops for me. You might need to call in subject matter experts to ensure against harm. For example, use of shaming language could be quite damaging, particularly to individuals who have experienced trauma. And what language constitutes shaming might be better determined by a trauma-informed expert rather than church or public health staff. Obviously, government agencies have strict budgetary guidelines, and most religious organizations at the community level are not swimming in excess cash. So the scope of the plan may have to be reduced from the ideal down to the doable, but working together to find funding across the community could also be a joint endeavor. Public health wants data. Many religious groups are inherently distrusting of data collection, particularly when the entity collecting the data is the government. Be mindful, make compromises. I'm a data-driven person. I love data. I'm a data nerd. That said, I would rather communities have access to recovery materials and resources rather than they not have them simply because I can't measure how well those programs are working. And finally, of course, there's the separation of church and state issue. I put this one last, even though it's obviously a pretty big deal. I put it last simply because smart people can always find ways of working together if they want to, and I don't mean by exploiting loopholes or being shady. The fact is that partnerships between different government agencies and public health in particular with faith-based organizations goes back a real long time in this country. But do work with your own leadership team and, if needed, legal counsel to make sure you aren't violating any local laws, regulations, or policy decisions. Speaking of longstanding fruitful relationships between FBOs and government, FBOs are engaged in several activities that have provided just such opportunities for partnerships. So I've listed several examples here, and of course there are a lot more, but faith-based organizations provide food banks and clothing banks. They're doing job training and education. They're doing actual in-school education. They're involved in justice-involved reentry. They also have Justice in Reach, where people from faith-based organizations go into jails and prisons. They're working in community empowerment, and they're working in emergency preparedness and response. They're basically, there's almost an FBO operation for every department of a local public health department that you can imagine. And in the area of health, there have been many such partnerships. Your organization may already, in fact, be partners in programs like the ones that are mentioned here. Just for clarification's sake, congregational health programs are programs that are intended to specifically raise the health of members of a particular church. That is, they're aimed at the church attendees in some way, or congregational attendees. Obviously, for reasons of church-state separation, such programs are likely conducted at several facilities of different faiths. Community-based interventions things to think about here, and I'll use this example again later in the presentation, is like a blood drive, right? Where the church parking lot is where the mobile unit is located, and the church helps with promotion among their constituency and maybe within the local neighborhood. But there are other things too, like they're doing health education. A lot of times the churches will be doing screenings and referrals, which is ideal for us. They're involved in physical activity initiatives, healthy eating programs, addressing health disparities, and substance recovery. And that is, of course, the area of most interest to us as a sort of a general category. The interplay between FBOs and substance recovery goals goes back literally to the dawn of this country, with church groups taking the lead in the 18th century temperance movement that evolved into the early 20th century prohibition movement. And although the wave sort of crested and rolled back with prohibition and its repeal, it still plays a powerful role today, perhaps most famously with Alcoholics Anonymous, although it certainly doesn't end there. In fact, and I've seen this number a few times, it's estimated that about 73% of substance treatment programs contain some spiritual component. I don't know necessarily how they measure that, but that corresponds to my encounter with substance use treatment programs. And the spiritual component could be a clear and explicit endorsement of the Christian God, but it is not always. Buddhists have taken the A model and adapted it to a mindfulness-based approach, which is pretty cool. And what's called the Red Road to Wellbriety is an adaptation of AA for integration with Native American Indian spirituality, which is also very cool. There are, of course, other examples. Recent studies on the role of psychedelics, for example, highlight the role of a quote-unquote mystical experience mediating recovery from alcohol or tobacco. And in fact, in another study, 82% of individuals who had a spiritual awakening during treatment for an SUD remained abstinent 1 year later, compared to only 55% who did not have such awakening during their treatment. In fact, many individuals cite religion or spirituality as a leading factor in their recovery. FBOs could have a significant impact on nicotine recovery in particular, and we'll see some examples of this later. Nicotine recovery, like all substance recoveries, is a long and winding road filled with obstacles, detours, and oftentimes failure. It requires a lot of planning, care, and attention to be successful. However, unlike with almost every other substance, there is no residential treatment option solely for nicotine. So getting support out across the community so that no matter where the individual goes, there's support nearby is important. And because the unique nature of nicotine use patterns, the desire to quit can change within mere hours. So we always want the option for support to be nearby. And FBOs are a great option here. Most neighborhoods have one or more faith-based organization, either a church or a service-based nonprofit in them or nearby. These places can do screenings, they can make referrals, and has been demonstrated in Shainberg et al. That's the second bullet point on this slide. They can be quite actual sources of care. There we go. Couldn't get that sentence out. They can use lay or peer health providers. Lay advisors, for those who have not heard that word before or that phrase, are individuals who work in or for the church but are not themselves members of the priesthood or clergy. They already have, that is FBOs, they already have deep roots throughout the community, and they can amplify their presence as a nicotine recovery resource wherever they already have such outlets. They already take a holistic view of health. Now, that isn't necessarily a component of all FBOs, but most spiritual or religious communities inherently understand the connection, at least, between spirit and body, and normally extend this understanding to other social determinants of health. And so they can talk about nicotine use in a way that is more dynamic and salient for the individual, potentially raising the impact of otherwise straightforward health information. Spirituality directly correlates with what has been called as a psychological concept, purpose in life, that's capital P, capital L, which in turn has been demonstrated to indirectly correlate with tobacco use. So as purpose in life goes up, then tobacco use goes down. And finally, church leaders or other church members may raise the awareness or esteem of certain evidence-based interventions that may otherwise remain unknown, distrusted, or ignored. Primarily here, I am thinking of how they might talk about the quit line, but we've seen a more recent study showing that church leadership can help raise trust about mobile cessation apps. That is apps on your phone, not mobile health units like the blood drive. As we mentioned at the start, having an honest, mutually respectful, and mutually beneficial partnership is key to trust and longevity. It's good to be clear-eyed about what you need from them and also what you're bringing to the table. Don't be afraid to leverage your role in your agency to make introductions to other departments or key players that you have contact with. Frankly, I think FBOs have a lot more to offer public health, or at least tobacco cessation programs, but that's actually a really blanket statement that doesn't say anything about local dynamics. However, most FBOs are doing what they can with what they have. To do any more requires more resources. And in my experience, resources, at least financial ones, are in short supply in tobacco cessation programs. But that said, public health is good at education and training, or at least connecting folks to education and training. And that can raise the capacity of the FBOs to do more or better work. To take one very low burden example, many FBOs are already running various support groups, and nicotine use is likely prevalent in the treatment community as well as at their group meetings. Simply educating that group facilitator on the role of nicotine in the condition and population their group hopes to help, and getting them trained in how to make a referral would be an overall benefit to the FBO, to the group leader, and any group member that follows that advice. And that may seem a little convoluted. What I'm saying is when they're running like a Alcoholics Anonymous group out of the church basement every Wednesday night, right? We know that tobacco prevalence, smoking prevalence is really high in that particular treatment community. And so getting that AA group leader trained up in the burden of tobacco within the substance use community and within their own particular actual group, getting them trained up on what that burden is and what those resources are is going to benefit all of them. All right. So here is what I recommend for homework before approaching the FBO that you want to partner with. First, identify what need your proposed program fills. In fact, identify all the needs. A program obviously should be designed to fill at least one need, but you haven't made the partnership yet. And their idea of their community need and your idea of their community need likely differs. It's good to pre-identify as much common ground as possible. Now, I keep talking about needs, but at this point, you should also be identifying the strengths of that community, which would include the presence of your intended FBO partner. Identify the ways you might leverage those strengths to satisfy that need, whatever need you identified. Then research the organizations, not just the intended partner, but any organization that you might engage with to address those needs in that particular community. Identify any areas of cultural ignorance that you may have. Educate yourself, right? Go online, get a book, talk to willing individuals in the community. Do note your outsider status. Do not demand education from community members, and do not expect to get educated for free. Once you are sufficiently competent, start to explore if the need you have identified truly exists. This is best done at the ground level, although I do understand that that is harder to do. Once you are talking to leadership, that's when you can start to identify where your goals and their goals align. What parts of your mission, vision, and values align? And trust me, there's going to be plenty of areas of overlap. I mean, as we've seen, public health and communities of faith are already working on so many of the same goals. But it's good to make the common ground explicit in all communications establishing the partnership. Once you think you have a pretty good understanding of a potential partner, the next step is to reach out to them and hopefully start building that partnership. I've divided how to do that into best practices and important considerations on the next slide. Best practices are the things you do, and important considerations are how you do those things. Although I acknowledge there's some overlap between how we do things and what we do. The first thing to remember is that partnership is a two-way street. Now, as an idea, just to talk about one of these areas of overlap, that may better fit as an important consideration. But in my opinion, it's better thought of as a practice because it has immediate, actionable repercussions. First, it means we lead by listening, asking questions of them and their perceptions of their communities and their community's needs. This will almost certainly mean connecting your own understanding of their community, correcting your own understanding of their community that you developed from the homework that you did. It also means that we aren't just willing to have our programs modified by the FBOs. Repeat that. We're not just willing to have our program modified by the FBOs. We want them to do it. We want them to modify our programs. Remember that tailored care works better than non-tailored care. We want them to modify our materials within reason and without compromising the actual qualities of the materials that make them effective. Look for every opportunity to give control of the program or its various components directly to the FBO, and that can feel pretty scary. As public health organizations or as providers, we're used to doing things ourselves most of the time, especially if we're paying for it or if we're responsible for it in any way. But remember, the whole point of these relationships is that they are trusted leaders for their communities, and we are not. The more of the program they are responsible for, the more it will be accepted by their audience. Be sure to talk through the program, looking for any potential conflicts, and make sure that everything is out in the open. We're aiming for radical transparency here. If you are radically transparent, then they are more likely to be, and there will be fewer unpleasant surprises down the road about how the materials were deployed, to whom, and in what manner. This radical transparency flows into the next two bullets as well. Being radically transparent about, for example, the reliability of future funding will make it easier to develop a sustainability plan. And of course, being courageous enough to reveal areas of conflict and be honest about difficult things is a good way to present yourself as an honest broker, a trustworthy partner. Remember that in building trust, the first step is to be trustworthy. Another way to demonstrate your trustworthiness is to set small goals and deadlines at the beginning of the partnership, goals and deadlines that are simple to achieve. Hitting benchmarks demonstrates competence and commitment. Related to developing trustworthiness is emphasizing a strength-based and trauma-informed approach. FBO communities are strong simply by virtue of being a community and the things that go into that. So explicitly recognizing their strengths demonstrates your respect and also demonstrates that you trust them to take ownership of your program and do good work with it. Demonstrating trust is another way to show your own trustworthiness. Finally, trusting the community to faithfully adapt the program for their own use returns us back to the top bullet. There are several things to keep in mind as you discuss the nature of your partnership. The first one here, for some of you, may be the most important one. It is critical that we don't enter into spiritual places and tell spiritual communities how to best practice their own spirituality. Right? We don't go into churches and say, I read that the body is a temple in the Bible, and therefore none of your parishioners should be smoking, right? That's just not our place. It doesn't matter if we're insiders to a particular faith or if we're just good students who did ample research. We just don't go to religious leaders and tell them how to interpret their own holy books or their own practice. Our role isn't to convert any group to adopt an anti-tobacco or anti-smoking stance. Our goal is to simply find those faith leaders who either see a spiritual connection to tobacco abstinence or simply want to partner with us because they want the healthiest community that they can have. Religious neutrality also helps us toe the line between church and state. We should remember that information about tobacco use constitutes health information and as such is protected personal health information. And of course, we already have mentioned the potential reluctance to participate in data gathering. So putting in measures to protect privacy and explaining those measures is yet another way to develop trust. Remember, maybe we're hearing a theme here. Remember that spiritual counselors have a specified scope of practice, and that scope differs from the scopes of practice of healthcare providers. We want to make sure we aren't asking them to expand their scopes beyond their capacities. Remember, we do want this partnership to last, right? We talked about sustainability a few times. Thinking of your partnership as long-term from the start and planning as if it will last for years is the best way to ensure that it does. Establish a regular contact schedule, be mindful of strategic or financial shifts that may put continuation at risk. Also, make sure you have more than one fruitful contact within the FBO and that they have more than just one contact at your organization. Excuse me. Finally, and we said this multiple times at this point, but do distinguish between faith-based programs and faith-placed programs. Faith-placed means that the program is being run unaltered at an FBO location. And not all of these are bad. This is not a signal of virtue of any kind. Again, think of the blood drive, where the only FBO participation is hosting the mobile unit on site and maybe adding some local publicity. A faith-based initiative is a program that has been recast in terms of the community of spirits, in terms of the community spirit appreciates and is reflective of their values as a community. Faith-placed programs can be fine. Faith-based programs are tailored care, which should result in more trust and therefore more impact. There are several ways to partner with FBOs for nicotine-related impact. I have listed just a few on this slide, and I have listed them roughly in terms of the level of cooperation required to do them. At the very top, from least to most cooperation required. At the very top, we have listed that the FBO could simply make referrals, something some FBOs are already pretty good at. Referrals work best when they are given enthusiastically from trusted sources, and that's what we would want the community leaders and the lay workers to do for us. To facilitate that, you should be prepared to give them a list of places that they can refer people to, including your local quit line. Explain what each of those referrals are and how they work and for whom they work, and hope they hope they take it from there. Encourage them to put lists and brochures out where their community can see them, whether that's a poster in the foyer or a bulletin board or in the community newsletter. Individual community members can offer themselves as support for individuals who are trying to quit nicotine. Now, this is different from running a psychoeducational support or recovery group. This would be purely volunteer endeavor, normally managed one-on-one, like coaching or mentoring. It would just be managed or coordinated at the FBO level, at the organizational level. Next up are the psychoeducational recovery or support groups. The FBO could simply be a host to such groups, right? They just rent the space out or loan the space out or give the space away for free. In these scenarios, the materials and the facilitators, they come in from outside. They come from the community. They might come from a local behavioral health organization. They might come from public health. They might come from a local volunteer group. But in any case, the FBO is just the host and doesn't run the group in any certain way. The next step up from that is when the FBO provides the group leader. The group leader comes from the FBO in some way. And then, of course, finally, at the end, we have tobacco counseling or coaching, which can be incorporated directly into other kinds of counseling structures that the FBO may already have in place. So I'm going to conclude this presentation with a closer look at two case studies. And it just occurs to me, I think in 2 slides from now, I have an error that I didn't correct. So I want to conclude with these 2 case studies. The first one is from a citation that appeared on an earlier slide. That's Shaneberg et al. And in it, they aimed to assess the effectiveness of a faith-based. I'm sorry, I think this is the slide with the error on it. Yeah. So this top paper is not the right paper. That's adults that use e-cigarettes was another paper I was looking at. I screen grabbed the wrong one. So here we go. They aim to assess the effectiveness of a faith-placed smoking cessation program targeting rural Appalachian communities, which is what it was, an area with high smoking rates and also significant health disparities in other ways too. This intervention was called, if you want to look it up on your own, it's called Faith Moves Mountains. And it was developed to leverage, this is as we described, leverage the trust and social networks within faith communities to encourage smoking cessation. The study involved 590 smokers across 26 rural churches, so this was pretty big. Participants did not have to be church members, but they did need to affiliate with a specific congregation for the program duration. This program used the Cooper-Clayton model. It's a 12-week smoking cessation group. I don't really know much more about it than that, unfortunately. I don't know what the content of that group is, and I desperately tried to find it for you all, but I couldn't do it. So there were weekly group support sessions. They used nicotine replacement therapy, and they used individualized motivational interviewing sessions. Overall, participants highly valued the program. So this actually, the paper on the back there, and then the paper that should be in the front here, one looked at quantitative results, the other one looked at qualitative results. So it's actually a really nice, robust set of studies here that we have. I'm sorry I did not give you the right picture, but I can give you the citation if anybody wants it. Anyway, the study identified 3 key themes regarding the participant experience and 4 themes related to the faith communities. I'm not going to go into all of these. The short version is that the participants initially felt, when they were sort of asked about the program, when we were talking about the program ahead of time, they actually expressed a lot of reluctance to join these groups because they the stigma of smoking was so high, even in this particular community where smoking rates were very high. The idea of announcing that to your congregational peers was they felt a little bit embarrassed, a little bit ashamed. However, once they got into the group and they saw that they were not stigmatized or shamed by the group, they ended up really liking it, and they really thought that the social connection boosted both their engagement and their success. The attendees also noted the convenience, which is of course another thing that we've highlighted during this presentation, is that 26 churches, that's a lot, and so you could sort of pick your spot. And then the churches, they felt that the churches provided a trusted and supportive space. And that's I think that's pretty much it. Oh, I'm sorry. And then the pastors themselves, the people who were running the group, viewed the program as a good outreach opportunity to engage both smokers and, interestingly enough, non-smokers. And the churches appreciated the program's alignment with their spiritual values of healing and self-care. So again, not nicotine recovery in particular, not this body as a temple violation or anything like that, but specifically embodying notions of healing and self-care, which is what they liked about it. Did I go backwards in some way? All right, there we go. So the second case study, and some of you may have heard me talk about this one before. I really enjoy this one. Both of these, I should point out, have like successes, right? The cessation rate there was 15.4%, which is pretty good. But then had this stigma thing, which is kind of an interesting complication, maybe a little bit of a negative, certainly something to think about during the enrollment and recruitment process at the beginning of the program. This study is very similar. It has both pros and cons. So in this second case study, researchers aim to test whether a brief intervention could change low-income smokers' beliefs about smoking cessation methods and how successful they might be. The intervention was conducted at Salvation Army sites in Wisconsin, where many clients were seeking emergency assistance like lodging, food, and financial aid. The study enrolled 245 smokers. 126 were put in the intervention group. They got additional education, and 119 were in the control group. They got sort of like a basic level of education. So participants were randomly assigned to either of these two groups. The intervention in the intervention group lasted about 10 to 15 minutes, and it was conducted by the Salvation Army case managers, so people who worked with the population directly. So the researchers did not directly educate any of the people seeking services. So this again, we're turning over control to the Salvation Army. And the intervention included an assessment of people's beliefs. So they would ask them things like, how effective do you think cold turkey is? How effective do you think the nicotine patch is? How effective do you think bupropion is? That kind of thing. And then after they gave their reply, they were given, this is part of the intervention, they were given corrective feedback. No. Cold turkey attempts are not 60% effective. They're closer to 5%, something like that. And then at the same time, they were given encouragement, like, oh, I think that you can probably quit if you really wanted to, and then resources. And specifically here, the resource that they were given was information about the Wisconsin Quit Line. So the intervention had some successes in changing beliefs about quitting, but about the success rates of different quitting methods, but it did not significantly increase quit rates, which is unfortunate. Certainly, that's what we would definitely want here is more quit rates or quit attempts. But it did effectively change their beliefs, although they did the intervention on one day and they did the follow-up like a month later. So how well did those corrections stick? And the answer is, it's a perfectly human way to do this. So the people really overestimated the success of the various methods. And then they were corrected. And then when they came back for their 1 month follow-up, they had corrected down from their original assessments, but they had not corrected them all the way down to the actual statistics, right? So if they initially thought that 60% of people who went cold turkey actually quit, the real answer is about 5%. They would bring it down to about 20. So a significant correction. So here's the other problem, right? Is that they did get better calibrated for their expectations. And in better calibrating how low the quit rates were, it actually kind of moved their confidence about their ability to quit down. And then I'm going to go, however, uh, 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 I'm sorry, the however is near the bottom of this slide. They were more knowledgeable about the quit line. They expressed a higher likelihood of calling the quit line. And even though they had decreased their confidence, more of the intervention participants had cut down cigarettes per day. So sort of an interesting balance that, so not a full victory here, but certainly I think you could tweak this intervention to get better results. So this is I'm moving into summary slides, and there's no reason to go through all this. This is literally the stuff I just talked about. These are the key takeaways that I think I'm hoping that you'll carry with you. One is that these are challenging for a variety of different reasons, but because of the role of spirituality and faith and religion in recovery attempts, this is definitely a partnership worth pursuing. And also remember that FBOs have deep roots in their communities. And for some people, going to their faith communities is the only time they get out in public at all, short of maybe this and groceries. And of course, groceries nowadays can be delivered. So for a lot of folks, this is the only place in the community where we can meet them. And of course, it's not up to us to meet them, but we want to empower the people that they do meet with in their churches and temples and synagogues, et cetera. We want to arm those people with the proper education and referral sources. And when we're thinking about how it is so hard, trust is the key here. Any way that you can develop trust, the key features here are the mutual respect, the open communication, not stepping into the religious space, not overstepping our personal and professional bounds. And then, of course, remaining flexible in how they adapt those materials that we want them to deploy. And I always encourage people to start small, right? You don't need to jump to the end or think that only having the most robust and complicated partnership is the only measure of success. If you can get a Quitline brochure or poster into a church foyer or the Quitline phone number into the church newsletter, that's a huge victory. All right, so that's going to conclude. That is going to conclude my comments for the day, and I'm open for questions. As a matter of fact, I'm going to go ahead and turn my video on and maybe even stop sharing. There we go. Here I am. Well, hi everybody. Hi, all these black squares with white letters on them, and Micah, whose picture's there. Any questions or comments about today's notes?
I have a comment. Hi, thank you. This is
Hi,
Michelle at
Nicole.
Adams.
Yep.
And I wanted to say thank you. That was great content.
Thank you.
And I wondered if you know of examples in Colorado um, of this, any type of partnership with FBOs that you could share.
I knew yes. The answer is I knew no. Jeez, I do know of a couple. Jeez, could not get that sentence out. Um, a lot of I don't know if Peggy's on the line, but she's worked with some housing groups that have religious affiliation, and there are a couple SUD clinics that have church backing that we know about that are sort of out there in the world. But none that I know of. I mean, I'm sure it's happening, but I don't know of anybody who's working like directly with a church. It's normally through like an organization, like a landlord who it's like a church that owns property, and then the property is, multi-unit, low-income housing or transitional housing or substance use facility that um, works with certain individuals. And of course, a lot of people have partnerships with hospitals, and a lot of the hospitals are uh, religious, like St. Francis or something like that.
Oh, okay. Yeah, definitely. Well, if anybody on the call is
Yeah.
doing work with like maybe churches and things like that, would
Is
love
anybody
to
on the line
connect
working with a church
with
or a
you.
religious organization?
We're doing some work. My team is, but I just thought it'd be great to connect, with others who might be doing that.
For sure.
Thanks, and
It's a
thanks
big
for the
crowd.
presentation.
Anybody here working with a religious or a faith-based partner? Well, then I'm really glad that I had this topic today.
Yeah, this is come off too. So yeah, hi, Tracy with Colorado
Tracy?
Black Health Collaborative. Hi. So one of the, community-based organizations we're working through the STEP program. So yeah, that is, one of the things that we do in terms of staying connected with our, church community and particularly as we work even with the No Menthol Sunday. I know it's a national observance that we stay plugged in and connected, but through tabling events and continued outreach and having them participate on our coalition. Um, we are, plugged into our faith-based organizations. So
That's wonderful, Tracy. So when you do tabling, is the idea there that you're sitting next to them, so you're sort of like, see, like we have their endorsement and vice versa?
yeah, it's kind of like actually they will perhaps put on an event, health-oriented event, in which, we're able to come and share information, at that event. So I mean, typically is through the health ministries that will connect in that way. And or we have, presenters coming in from community to also, present. So yes, we do have that opportunity to collaborate and then be, viewed as, trusted, community because we're
Yeah.
walking alongside them and showing up in spaces. Sometimes it may not necessarily be health oriented, maybe something different. We are still showing up in that space.
And Tracy, is that church group, are they a part of the collaborative? Is that how you made that connection, or was that something that came out afterward?
Well, yeah, we deem them as part of community. So they were always involved in the work when the Colorado Black Health Collaborative,
Mhm.
first came into existence. So they were part of community. And then as we, stepped into this space, as we're dealing with tobacco nicotine, there was a natural, affinity in terms of our already existing relationship with them that we were able to continue to keep collaborating. But again, going back to their health ministries,
Mhm.
because they have a focal point of the health and wellness of congregants and those in community, we were able to tap into, that connection and continue to do so. And with that, as we formulated our coalition, as we came into tobacco nicotine space, we said, okay, we want to make sure we're pulling in representatives from those health ministries to participate, in our coalition.
Wonderful. Thank you so much.
Mhm.
And I
You're
didn't
welcome.
go too much into it, but Tracy just said a word there that I don't know if everybody's familiar with it or not, but a lot of churches do have health ministries. So ministries are like, I don't know exactly. I don't know. I don't want to be unfair. They're like little like focused clubs within the church, little communities within the larger community that focus on very specific issues. And so a lot of churches will have health ministries that you can connect with. They'll have youth ministries is very common. Obviously, men and women ministries. A lot of them have social justice, community focused ministries, and those are like sometimes that's the individual that you'll work with because they're like the real program runners, right?
Mhm.
Yeah, Michelle, go ahead.
Yes.
Thanks, Tracy, and good to see you. Sorry, I'm not showing my face, but I have no
It's okay.
makeup on and haven't faced the day yet. Um, but I was just curious, Tracy, since you brought up No Mental Sunday, which is happening in May. We did a little bit. Julia did a little bit of outreach for No Mental Sunday last year, and would love to do that again and even increase that outreach. And so we used the materials from Center for Black Health and Equity's site that leads that. Is there? Um, I'm just wondering, should we? Is there any kind of Colorado momentum, state level momentum that we could join for that event, or should we stick with the going to those folks on their website?
Well, and we use it, and I'll let Terry, I'll see if Terry's on here too. So will
Yeah,
Terry jump in?
uh-huh.
Yeah.
Yeah, yeah,
Okay.
That's what Terry earlier. Yeah.
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 I'm still on here and I was just listening. Tracy, did you want to comment? I was gonna say a few things on it.
Yeah. Other than I would say we're using the Center for Black Health and Equity as well too. Again, they were the national entity that kind of started this momentum with this national observance. So they've got a lot of good, great material. But we kind of view it as an opportunity to plug into the greater movement that we have happening on a national level here in Colorado. So we've been working through, and I'll let Terry expound on it a bit more as well too, about how to individualize it. But our objective is to make sure that we are bringing in our faith-based um, community members so that they also own it. We're not the one necessarily having to run it, bringing them up so that part of that work is having to help educate and inform them and make them aware and help them to help own it. So we're kind of still in the process, of that as we're now kind of think going into year 3 of, participating with this observance. So I'll defer there.
Yeah, and I was just going to add that last year we did try to at least work with one church directly
Mm-hmm.
to give them an idea of how to do this. And you talked about the stigma of smoking in the churches. And as we started out the program, people seemed to be a little reluctant, but as one of the ministers came forward and said, hey, he used to smoke, of course, that kind of
Mm-hmm.
drops the bar a little bit. Okay, if he did it, then people were willing to share their stories. So it was more about sharing stories and then what can be done about it. But like Tracy was saying, having the church people own it rather than us saying, hey, we're going to come in and do a program. We educate them about what No Menthol Sunday is all about. And because those resources are already done, it makes your job a lot easier. You're working smarter, not harder,
That's
using
right.
their materials, but we have the connections with the people. So just trying to leverage those connections and say, hey, we're here if you have any questions, but we'd like you all to try to put something together. And that does work. And to know that we're a resource, but they don't have to know it all. There's materials that can have them put together something for that day. And our next phase is how do we take it beyond just that one day? Because people do get excited about that. But we're happy to help out if some people want to know how they can do it in their community. We're happy to kind of share how we've done it and how we've approached it.
Thank you so much for that offer, Terry, and for sharing how that went. I'm happy. I'm always happy when I hear things that I said like from this like didactic ivory tower thing, and then you and Tracy come in and say like, yeah, no, we experienced some of that. I'm like, yay!
Yeah, it's real. It's
It's
real.
real. I'm not just making it up.
Yes.
All right, everybody. Thank you so much for joining us today. We are 2 minutes past time. Thank you. This recording will be available probably within the day. So I'll send an email out. I'll send an email out letting you know where to find it, and also along with the evaluation. So you can tell me how you think I did and also make recommendations for the next one of these. Otherwise, ta-ta. See you next time.
Thank you so much.
Oh, sure.